So it is 9:01. So at this time, please ask everyone to please rise for the pledge of allegiance. Commissioner Kirk, Willie, would you please lead?
Sure. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. I didn't do it.
I get my swimming glasses.
Didn't do it. Excuse me for a moment.
Okay, this morning,
This time-
wants to change his period.
Do roll call. Have you heard from Commissioner Birdie?
I have not heard.
Dr. Tribble, I do believe is, yes, he is on the.
Yes, he is on.
Line. Zoom. Arlen. Commissioner Levy.
Here.
Commissioner Brooks is, I understand, on his way. Commissioner Willie.
Here.
Now I'll ask, is there any changes to the agenda anyone wishes to do? That could be informational guidance. Yeah, that's good. With the agenda presented.
So moved.
Been moved and seconded to approve the agenda as presented. Any discussion? Hearing none, all those in favor?
Aye.
Aye. There is no in-person public comment. Now we're with the introduction of new employees.
Good morning, everybody. We've got one person here that we're going to introduce today. And go ahead and stand, Dylan. This is Dylan Turner. He is joining our EPI team and has been here a month now. Since December. Yeah, fantastic. Tell us a little bit about yourself.
Hello, my name is Dylan Turner. I'm originally from the state of Ohio. I completed my master's degree in Scotland, though. So I have a little bit of experience both in U.S. and international, both human and wildlife care.
And what will you be doing?
I'm working with the epidemiology team, but I did my master's in infectious disease.
And he was able to jump right in, and it's been fantastic.
Thank
So
you.
very helpful.
I'm glad to be here.
So good to have you. Thank you very much.
Thanks, Dylan.
Thanks. Okay, I asked for, has everyone had a chance to look at the meeting minutes? Ask for a motion to approve.
We approve the minutes as presented.
Move seconded to approve the minutes as presented. Any discussion? Hearing none, all those in favor?
Aye.
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 Apologize, you didn't see Commissioner Brooks when he came in, so he is now present, so thank you, Commissioner. Now at this time, we will have the June 2026 monthly expenditure and revenue report. That will be Dawn.
Morning. Normally, this is a presentation that Michelle gives, so you're stuck with me. I apologize for that, but we'll go through a good story that's easy to tell here. If you look at the revenue expenditure report from your packet, you'll see in the upper right-hand corner, that's for June 2026. So that shows the end of the fiscal year close. The target being 100%, right? That means 100% of the fiscal year has elapsed. The next important portion there is the year-to-date column, which is just a little bit to the left there. Our net revenue, just a little over 15 million. Our expenditures, just $40,000 less than that. So we came in slightly under. We had a little more money come in than went out the door, so that's a good one. If we scroll down, we have all the details which we can I'll do my best to answer if folks have any specific questions in there. The ones that I would draw attention to next, if you just scroll down, down, down in that same column year to date to the bottom, you'll see our budget for the year was 16,366,000. We ended up spending 15,167,000. So that's also good. We're just a little under budget, just slightly under $2 million under budget. But within that amount, a significant slice of that was the committed funds there in the yellow band. You'll see in the middle, we spent about 800, let's see, about 850,000 that was just under budget. 853,000 of that total underspend was related to the committed funds. So if we tease that out and think of that as kind of that committed funds are going to happen the way they're going to happen, our total budget, we came in just about 2% under budget. So we consider that to be success, that we're tightening the belt and managing the money in a good way, spending it like it was ours and trying to stretch it as far as we can.
Is that 2%? Is that about what the range where we normally have been in recent years?
You know, I didn't prepare the exact amount because we had some oddities in the last couple of years where we had some funding that was expiring and we were I guess I could answer the question better next month. I could give you a little better trend. I think it is slightly less than what we spent in the past, or we've underspent in the past, but also we had some anomalies that influenced those to be a little higher than what I would expect normal operations to.
Should know that being here in recent years, but I don't remember.
No, there's a lot of numbers, right? So yeah, I think
I feel like the last few years have been
a little bit
of a roller coaster because we had COVID funds coming, growing,
right.
change in federal funding, and then also just some Luma changes. And last year with having turnover of our financial team, something like described here, there's some revenues that showed up this year because we were behind in billing last year.
Yeah, there's some atypical things like one-time expenditures that didn't happen or one-time monies that did. And so to tease those out and say what would be our normal steady state operations takes a little bit of time.
Yeah.
So, but I can get that for you next time.
And just on Luma, is everything pretty smooth now with Luma?
There are improvements on both sides. I would say that Luma is getting better. From when it originally rolled out, there were a number of what we would consider to be key functionalities that were not yet completed. So we were forced to kind of manually replicate those in-house while they were building some of those. So since Luma rolled out to date, there have been quite a few improvements, more reporting, more automated reporting out of that so that we can not invest time in manual tracking, but rather we can use that as the system of record. Another improvement in that relationship, if you will, is our team has developed confidence in the tools that are there. So some of the tools were there, but they were really hard to navigate and find and connect to the right things. So it's getting better. We are getting better as well. And looking forward into this fiscal year, we have some pretty exciting pieces that we are working on to make that even better. Tools that we're kind of plugins we're building in-house to make it much easier for our team to feed the system, extract data from it in a reliable way, and then easily and reliably and at a pretty tight time interval, distribute that information to our managers so that they have as close to real-time status of their spending as they can. So just trying to make the data flow easily to where it needs to be. And I think we're making good ground on that. So now that's the good story. We're now a couple weeks into our fiscal year, and almost daily I receive updates from the state controller's office regarding, oh, this didn't quite load right and that didn't quite load right. So I think they're still learning, but it's nice when they tell us, hey, this is not functional, so don't rely upon that piece yet, and we'll tell you when it's ready. So I think it's an improving system, but it's very complicated and it's taken them some time.
Thank you.
Do you want to go over expenditures?
Come on.
The expenditure page, again, we came in a bit under budget. We did receive a few less dollars in those committed funds that we were expecting to receive. So I don't know that I have a lot to expand upon what Michelle's presented here in the table. No questions. We can move on to the grant page as well.
Any questions? Go ahead.
Yes, okay. But I guess 2 pages further back in your packet, we have the contract services and grant application report. That's a portrait or landscape rather layout with a blue bar across the top. We have one grant or contract, or pardon me, grant that we are in the process or considering applying for. It's for $200,000 per year. That would be for 3 months or 3 years. So that would be a good chunk of dollars, just over $600,000. And as you'll see there on the right, that's to assist in substance abuse and mental health services. We would propose to expand our training in QPR, crisis continuum of care, and mental health first aid across all 6 counties. One, I guess, slight drawback to this funding source is we are limited to an 8% indirect. Our indirect rate at the district is closer to 30%. So the district would need to fund the balance of that. But if we think of it kind of in the total match scheme, if we count the money that we would potentially get from this along with our match, it looks like we would get potentially about 80% of the total cost covered by this grant, which to me feels like a pretty good exchange to pay 20 cents on the dollar for 3-year duration. That gives us a chance to build what I think are some more sustainable systems and benefit a number of folks.
This grant, how much into the substance abuse and mental health services, or is it looking to do? Is it better in competition with our WITC, or is it going to be a benefit to the WITC? I mean, you just kind of want to know, what are they just going to do like WITC does and just people come in and try to get them some services, or are they going to have service?
I can speak to that a little bit. So it should be an increase to what is happening now. There would be more interventions for suicide prevention primarily, and then also I think they were going to use potentially some of the Guiding Good Choices programs. We'd be able to get more groups through for that. So it would be an increase in the amount of people served, not just continuation and then just taking away costs. It would actually be an increased number of individuals served.
And I believe this is not like a direct care grant. This is an education grant. So like the scope under the purpose talks about training EMS and other first responders and like mental health first aid.
Yeah, so there's something direct to, I guess, residents or clients, and then for education, and then also, like you said, I believe also for education for other professionals that then carry out additional work. I think Caden would be the one primarily working on that program to develop it. If you remember her.
Well, thank you. Anyone else have any questions? Thank you. Good. At the end of our budget report.
Don, what is the timing of this? This is an application, right? When do you know?
I think the application deadline is pretty soon. I want to say it's within the next couple of weeks.
I actually submitted it yesterday.
Oh, okay.
Then it got kicked back, so Diane's working on it still. But I think the deadline is today.
Yeah,
When would you find out about that?
Usually it takes about 30 to 60 days.
Surely they told me at least 3 months.
Oh, 3 months. There you go. 90 days.
time. Of the safety team presentation. Melanie,
She'll be 1 minute. She's doing some last minute.
okay.
I'm up. Oh, no, I have. Oh, John.
Y'all, I'm so nervous. I don't even know why. It's so funny. Okay. I'm gonna try and keep it at 5 because I get really excited when I talk about this stuff. Okay. Good morning, Mr. Chairman and members of the board. I'm Melanie Croninger, Senior Health Education Specialist here at Southwest District Health for their Drug Overdose Prevention Program, where I've worked for the past 4 years. One of the reasons I'm especially passionate about this work is that I bring both the public health expertise and lived experience in recovery. Having maintained recovery from substance use for more than 20 years, got sober at 25, I understand firsthand the importance of creating systems that support prevention, treatment, recovery, and long-term wellness. That perspective has strengthened my commitment to building partnerships, reducing stigma, and ensuring that individuals with lived experience have a voice in developing solutions, because meaningful change happens when the people most affected are included in the conversation. So today I will be presenting on the Public Health and Safety Team, a collaborative approach to preventing overdose deaths in Canyon County. What excites me most about the Public Health and Safety Team, or FAST for short, so FAST with a PH, is that it brings together people who might not otherwise be sitting at the same table. It creates opportunities for shared learning, collaboration, and collective action, and I've seen firsthand how those partnerships can lead to meaningful community impact. So if your community is experiencing overdoses and you are interested in this model, we are happy to assist. Just want to make that clear, because it is Canyon County, but it's a model that can be duplicated. Okay, next slide. Oh, you're so good. For the presentation, I'll provide an overview of the Public Health and Safety Team, or FAST. I'll discuss why FAST was created, the framework and guiding principles that guide our work, our goals, and the progress we've made to date. I'll also highlight the diverse Canyon County partners involved in FAST, share some of our key accomplishments, discuss what's coming up for Canyon County, and conclude with a public safety perspective from Lieutenant Bradley Childers of the Nampa Police Department, who serves as our FAST co-lead. Thanks for being here, by the way. Okay, so I can anticipate my okay. So why FAST? The overdose crisis has many different systems. Public health collects and analyzes data. Healthcare treats overdose and substance use disorder. Law enforcement and first responders encounter people at risk every day. And community organizations provide treatment, recovery, and support services. Historically, many of these systems worked independently and often operated in silos. FAST was developed to break down those silos and bring these sectors together around a common goal and create opportunities to share information, identify gaps, and coordinate prevention efforts around overdoses. The idea is simple. No one organization can solve this problem alone, but together we can have a greater impact. I think it's when I turn the page. This slide change is so great. Okay.
May I ask you to take just a quick pause and let's scoot you a little bit closer? Monique said they can't see you. I know you want to be seen.
Oh, so bad.
We're going to scoot it a little bit closer this way. Yeah. And then give me just 1 minute to scoot back to my computer. Sure. And talk to my people.
Okay. Thanks, Monique.
Yeah. Hang on here. We're going to make sure it's all good to go.
Still not quite in that camera.
Okay.
Oh,
There, now you are.
a little bit. Awkward. It was like watching me just knock this thing over. I'm so sorry you're in the splash zone. Okay. Carrying on. Thank you. So FAST is a national framework we've adapted, and it is built around 4 guiding principles. The first is what FAST calls the North Star, which is reducing overdose deaths. And that's it. So this shared goal helps partners stay aligned even when they bring different perspectives to the table. Second, we recognize substance use disorder as a chronic treatable disease. This helps reduce stigma and encourages approaches that support treatment, recovery, and long-term wellness. Third, we use data to guide our decisions. Bringing together information from multiple sectors helps us better understand what's happening in our communities and where prevention efforts are needed. And so not only are we at the same table, but now we're ordering off the same menu. And finally, continuous improvement. We continually evaluate what is working, identify challenges, and adjust our strategies to improve outcomes. So what is the SOS framework? FAST uses what is known as an SOS framework. The first goal is shared understanding. We work together to develop a common picture of overdose trends, emerging threats, and local needs. The second goal is optimize capacity. By understanding one another's roles and resources, we can identify opportunities for collaboration and avoid duplicating efforts. The third goal is shared accountability. We monitor progress together and use data to determine whether our efforts are making a difference. In simple terms, FAST helps us move from information sharing to coordinated action. So FAST engaged 22 diverse stakeholders from various sectors to collaboratively address overdose prevention. This represents double the stakeholder participation of the previous 2 years. Current partners include law enforcement and first responders, Canyon County Coroner's Office, Probation and Parole, Canyon County Prosecutor's Office, forensics labs, health systems, diversion programs, treatment and recovery organizations, and we also have the Overdose Response Strategy, or ORS team, which brings together a CDC Foundation public health analyst and a HIDA agent. So HIDA stands for High Intensity Drug Trafficking Areas, which includes Canyon County. One of the greatest strengths of FAST is the opportunity to bring these different perspectives together to discuss local issues, trends, and opportunities for prevention. Each partner contributes a unique piece of the puzzle, helping us better understand the overdose crisis and identify opportunities for intervention.
Can you tell us what other counties might be in that HIDA category?
Ada County, Twin, and then North Idaho. So, but
Big populations.
Yes, basically it's the interstates that drug traffickers use to transport drugs to the Pacific Northwest or other ways. Yes, but lots of other counties touch HIDA counties.
Right.
So. Excellent, thank you. One of FAST's greatest accomplishments has been building relationships across sectors that do not traditionally work together. We've established regular meetings and increased participation from public health, healthcare, public safety, treatment, recovery, and community partners. Another key area of progress has been data sharing. Through the FAST data inventory process, partners identified available data sources and gaps in the information needed to better understand local overdose trends. We are transitioning from a SharePoint-based spreadsheet, thank goodness, to a streamlined online reporting form, making participation easier and improving reporting consistency. Data collection includes preliminary and confirmed overdose deaths, drug-related arrests, individuals on community supervision, and treatment admissions, among other indicators. FAST meetings also provide opportunities for shared learning. Each meeting features a presentation on an innovative program, service, or resource. Most recently, partners learned about the Integrated Law Enforcement Diversion Program, which connects eligible individuals experiencing substance use challenges with treatment and recovery service as an alternative to incarceration. Planning is currently underway for Idaho's first overdose fatality review process. OFRs bring together partners from multiple sectors to examine overdose death, identify opportunities for prevention, improve coordination across systems, and develop recommendations that can help save lives.
Tell us how do overdoses, if they don't result in a death, how do they get cataloged?
That is a very good question.
Do they?
They do. And so they are reported if the EMS arrives. They're reported in their system, which goes to the EMS Bureau, which then I have access to. It's called the Overdose Detection Mapping Application Program, ODMAPS. So that is one data platform where we can see near real time both fatal and non-fatal overdoses. We also have law enforcement tracking it. Anyone who's on supervision, probation, and parole. Typically, They share with their supervisor, their probation officer.
So all of those sources feed into that report.
Yes. Okay. All right, next for Canyon County Fast. As we look ahead, there are several opportunities to strengthen this work. Our biggest priority is implementing and sustaining the overdose fatality review. Additional opportunities include strengthening data sharing practices, expanding partner engagement, and using findings from our partnership to inform evidence-based prevention strategies. At this time, our focus is not growth for the sake of growth. Instead, we're focused on strengthening the partnerships we already have, building sustainable processes, and continuing to improve our understanding of overdose prevention needs in Canyon County. All right. I'd now like to invite Lieutenant Bradley Childers from the Nampa Police Department to share his perspective on FAST and the value of collaboration between public health and public safety. Lieutenant Childers.
Hello, and thank you for having me. I'll be fairly brief on this. I think the biggest question is why? Why does law enforcement want to be a part of this? Do we benefit it? Regardless of what agency you work for, there's one common goal, that's to keep our public safe and then to reduce crime. So from a law enforcement stance, originally when we go out to someone who's using drugs, it's handcuffs, go to jail or the hospital. If it's worse than that, an overdose, maybe we're applying Narcan. And then that was it. It was on to the next call. That's where law enforcement has now changed, taking a different direction, is collaborating with people that know a lot more than I do about this type of stuff. Using data-based information, find more of a root problem. For us, it makes no sense for law enforcement, for taxpayers to pay cops to go back to the same house over and over and over again, just to do the same act. So let's find a root problem for this, get these people treatments. We're not returning to the same house day in and day out. Whether I solve that problem for Nampa and say, okay, I moved you and now they move over to Caldwell, it's Caldwell responding to those residents. So I think it's the collaboration that's also such a big benefit for not just Canyon County, but specifically for the Nampa Police Department to have a lot more resources that we can reach out to. One interesting thing is once all the entities start talking to each other, get on the same page. I think our first meeting was in here a little over a year ago, and we had 5 people in here. And now when we're on a Zoom meeting or meeting, it's 20 plus. And so the collectiveness on it has been very, very powerful. You can see people buying in more and more. We just recently did a tour about a month ago, the Canyon County Jail. So for me, that's when these people go to jail because they had the drugs on them, is there some type of resource that we can get them so that I don't have to visit them again with my police officers at their house or overdose. To touch on your question about does it get reported? We had 3 months ago-ish, give or take, we had 6 overdoses in one house on the same night. Some kids went partying downtown Boise, came back, continued to use some of those same drugs and had an overdose on that. So now it's that communication portion of where did they get that? How can law enforcement now be effective? One of my roles currently is I'm a lieutenant over our narcotics division. So it's a nice little plug that I can grab my detectives and say, where are they getting this stuff? Where's it coming from? What's HIDTA doing about this? We never had this option before to communicate. I never have at this level. So we get the numbers from the sheriff's office, Middleton PD, the drugs happen there too. So we're able to talk together and hopefully send cops less to the same house over and over again. That's the plan. Is there any questions for me on this, on why this works? Yes, ma'am.
So where are you sending them and what kind of success are you having? I mean, what's the end? The end goal is to get them off drugs. Is that happening or?
Yeah, it is. We had Corporal Hoaxma talk last week and he's been doing the LEADA program for roughly 3 years, maybe up to 4 years now. And he has 33 people within the program. I think he had 15 successfully completed. That's, if you average 3 calls of service per year to the same household, which is the average for Nampa Police Department drug call, it's quite a few calls. So we are having some wins on that.
So what program is that? I mean, it looks like there's maybe a lot of duplication of services.
Yeah, that was one of the questions that I came into, like who's helping who on this. There's a heart-to-heart talk that we had, and we're trying to lean towards nonprofit, not for-profit organizations that truly kind of have their heart in the right spot on helping us out with this venture. So they continue to come to us with suggestions, information, how we can hand that out. Pamphlets being handed out from not only just EMS and fire now, but also police officers on what these people can do. Oftentimes, honestly, it's left with a parent or a friend or a family member that will have that sit down conversation with this individual and be like, you need help, take this. Then it's kind of up to them. Can't force somebody to do something, but you can suggest it strongly. Did that answer your question?
What kind of?
Okay. Yeah, we are seeing success. Obviously, it would be nice to say, all right, no more drugs, no more overdoses. Maybe I would have to find a different job or something, but that would be okay too if our community is that safe. But we're not making that big of steps yet. Going in the right direction with it for sure. Yes, ma'am.
We see that people are in our jails, they get out and they just go right back to it. And that's what they say. They're just sitting in there and think about when they're going to get out so they can get high again or whatever it is, you know. So does part of this focus on those people
That
released?
I think that's our biggest next step that we just, when we did a tour of the jail of like, what resources Candy County Jail provide right now. It started my career there. It's a wonderful place, but I don't know if there's a good source of information for these individuals. A great idea that came about was individuals can have iPads in there, basically watch shows. So one of the ideas is to give them education during that show that pops up. Like, hey, if you want to watch this, if you want another 2 movies you want to watch while you're in jail, take this course. And through that course, they'll give them some information while they're sitting there in jail thinking about what's my next step. Like, oh, well, maybe I should contact this group when I get out to see if I can get some help for this.
So is that a thought to do that or is that being done?
That's not being done yet. No, that's just a thought. We live. Yeah, that's
Brainstorm.
a brainstorm idea, but I think it's super feasible. I mean, it makes sense.
No brainer to do that.
Yeah, but we just went to the jail recently. So like, how do we? They don't bring a lot of resources in there. The other part of that too is sometimes they're in only for a week or a weekend, but we could get that information within that weekend. Questions? Any other questions? Thank you for your time.
Thank you, sir.
Before we move to our final slide, I'd like to take a moment to recognize Lieutenant Bradley Childers. Lieutenant Childers, please stay right where you are. Okay. Southwest District Health is honored to present you with a challenge coin. Challenge coins originated as a military tradition to recognize exceptional service and leadership. At Southwest District Health, we use them to honor individuals and partners whose contributions have made a meaningful impact on public health in our communities. As co-lead of the public health and safety team, Lieutenant Childers has been an exceptional partner in strengthening collaboration between public health and public safety. Most recently, he helped facilitate a fast tour of the Canyon County Jail, providing partners with valuable insight into the experiences and challenges individuals may face as they transition back into our communities. Through his leadership, willingness to open doors, and commitment to collaboration, Lieutenant Childers has helped strengthen our collective efforts to prevent overdoses and improve community health and safety. Lieutenant Childers, on behalf of Southwest District Health and our FAST partners, thank you for your leadership, partnership, and dedication to the people we serve. It's my honor to present you with this challenge coin as a symbol of our gratitude and appreciation. Congratulations and thank you.
Appreciate it.
Surprise! Okay. Last slide, please. Yeah, we're there. All right, I'll close with a few key takeaways. FAST creates opportunities for public health, public safety, healthcare, treatment providers, and community organizations to work toward a shared goal of reducing overdose deaths. The partnership helps improve communication, strengthen collaboration, and identify opportunities to better serve individuals and families affected by substance use disorders. We've made significant progress building relationships and laying the groundwork for future initiatives such as an overdose fatality review. Ultimately, FAST demonstrates that when agencies come together around a shared mission, we are better positioned to prevent overdoses, save lives, and improve community health and safety. Again, if your community is experiencing overdoses and you are interested in this model, we are happy to assist. Thank you, and I'd be happy to answer any questions. Any questions?
What are you seeing or it's not a trend? I've heard that they're actually dropping.
Yes, nationally they are dropping. Locally, we also see that as well, but then some of the things that we've noticed is data collection, the way that it's being provided. We might be struggling to get correct data into the systems to have good data. And so when we meet at the FAST, if it says, like in the OD maps, I talked about that program that says no overdoses, but then we come together and we're like, no, wait, we saw 2 here and EMS went to 3 there, then we know that there's an issue with data. And so in some of the, I know Payette County had its first fatal overdose this year, I believe, last week. And so we're definitely seeing a trend downward, but they're still happening. Yeah, and we could have really gotten into the weeds today. We just wanted to give you an overview, but the FAST is doing so many different things, even if it is coming up with, we may not be solving the problem, but we have partners at the table that can. So.
I know we may not be in the high trafficking identified area, but we have so much coming over from Ontario. It's just like right across the bridge. By far, substance abuse is by far the highest
Absolutely.
crime that. So.
Mount Laird County is also a HIDA location.
Right, and they're coming right over.
Exactly. So it affects, it's a ripple effect. It definitely affects.
Some of that, I mean, intentional, or I mean, as in, some of it laced with something fentanyl, is that a lot of it, what's going on, or is it just, I mean, just kids doing too much, doing drugs?
That is a great question. And there is definitely a difference between overdose and poisoning. Overdose is if you take more than you anticipated, where poisonings are unsuspecting because they don't understand that there's a lethal dose in whatever method of what they're taking, whether it's a fake pill or something else that they thought it was. We're seeing fentanyl and other synthetic opioids being mixed in other drugs like methamphetamines, which is a surprise for someone who uses methamphetamines and that's all they think they're taking. And they're opioid naive, where they don't have any tolerance to it. And so, yeah, we're seeing some of that too. But what we get to see, right, when we look at the data inventory tool to answer your question is like, that's what we want to look at. And we'll maybe come back and present some of these stories from the data inventory. So maybe we see a lot of arrests 1 month and a lot of, activity 1 month, but then we see a lot of people entering treatment the following month, right? Maybe that's how we know people are getting help or being diverted or choosing something different. A lot of people, because jail is at capacity, they do a pre-trial release. So instead of incarcerating them, they just say, okay, come back to court when it's your time. So, but we definitely are trying to make the biggest impact we can to help folks get going on the health of our community.
Thanks.
Yes, and it's also open if anyone wants to come join our FAST and see what we do. We're always welcome.
I'm coming. Maybe just when Lieutenant Shoulders was talking about the jail, it made me think of some conversations we've been having. I can get back because it's her team in the pre-prosecution diversion program. We had met with the sheriff and new jail commander recently about so right now, the way the pre-prosecution diversion program works, we work with the prosecutor's office. We haven't really worked on the jail side of things to identify people who also might benefit from the pre-prosecution diversion program. And that's geared towards mental health and substance use, individuals who are struggling with those. So I wonder, just like you were saying, if there's maybe a connection there that could happen. To share.
Anything is better.
Did you?
Yeah, we've been doing about the guys. Maybe they can trade intervention, their sentence.
Yeah, all is all.
I don't know how much you've talked to Michelle, but
Veronica is on our public health and safety.
oh, well, perfect.
Yes. So we talk about it.
Yeah, and she may not know about some of these other conversations that have happened because.
Excellent. We look forward to it. Our next meeting is August 3rd. Monday, August 3rd at 10:30 a.m. here in this room or online. Any other questions? Thank you so much for your time. I appreciate it.
Thank you. Thanks all for exit.
Yeah, everybody's fine.
Thank you.
It's like Josh, you gotta know.
Disease update.
Before you start, we're going to try this one more time. We saw half the balance, so.
That's what I'm doing.
I know, and I'm sorry she's writing your notes. Let me check here, Lakshmi, if you'll just give me 1 minute. Thank you. You're good. Thank you. Good morning, Chairman and Commissioners. My name is Lakshmi, and I'm the Epidemiology Program Manager here at Southwest District Health. And I have been serving as an epidemiologist here for more than 5 years now. So thank you for the opportunity to present about this topic today. Today, we'll be walking through a situational update that we are currently monitoring about 3 different diseases or conditions. That is the New World Screwworm, highly pathogenic avian influenza, H5N1, and cyclosporiasis. So for each topic, we'll be covering what the disease is, where things stand right now, and how Southwest District Health is responding. Next slide, please. So New World Screwworm is a fly that primarily affects livestock, pets and wildlife, and occasionally humans too. So the adult fly is about the size of a common housefly or slightly larger and can be identified by the very distinctive metallic blue-green body, which kind of tapers towards the ends. And what sets it apart from an ordinary fly is that the larvae of the fly feed on the live tissue of warm-blooded animals. And this include animals, livestock, humans. And what makes it so destructive is that the larvae tear into the wound of the live animal with their sharp mouth hooks. And as more and more larvae hatch and feed into the wound, it grows and gets deeper. And it can frequently be fatal, especially if not treated early on. The key reassurance here is that we have not had any detections in Idaho at this time. So next slide. The current situation over the past 30 days, there have been 41 detections of New World Screwworm in Texas, in their cattle, sheep, and goats. And there have been 1 New Mexico case in a domestic dog, 0 human cases reported in the United States. And what brings this to our attention is that this pest was eliminated from the United States roughly 60 years ago, and now it has returned. So that's the concern. But cases remains geographically limited, and what matters is that we are doing everything to make sure that it does not get transmitted across the country or reach Idaho. And next slide, please.
Do you know how it was?
Yes. So a little bit of background about the worm. To put that impact in perspective, screwworms caused about 180,000 livestock deaths in Texas back in 1935. And this was eradicated in 1966 using the sterile insect technique. And this method is very straightforward. The male flies are sterilized with radiation and released by millions into the affected areas. Because the females mate only once, those pairings produce eggs that never hatch, and the population of the fly collapses in the region. So since 1990s, a joint USA-Panama Commission has continued releasing sterile flies to maintain a barrier at the Panama-Darien Gap. And the barrier has now been breached. And this is because of the livestock trading from south of the border into the United States mostly. And detections were confirmed north of the barrier in 2023, and the pest moved up through Mexico. And I believe this year it moved across the border and moved into the United States as well. And because if the infestation establishes in the United States, it can cause a loss of damage, especially in the livestock industry, and can be detrimental to the economy. That's why they have a high focus on the screwworm now. So moving on to the next slide, we will cover what the federal government is doing with regards to responding to the screwworm. So they have FDA have authorized 2 new animal drugs in April for treating and preventing screwworm in animals. So they had closed all the southern borders for almost a year now for livestock trading because of the increasing number of cases among livestock in Mexico. And on July 24th, last Friday, the USDA announced a phased reopening of the South ports for livestock trading beginning on August 24th. 2026, and every animal entering the United States through these ports will undergo a full USDA inspection to ensure it's free of any signs of New World screwworm. And next, we will move on to what Idaho is doing. So ISDA has issued an administrative order that any warm-blooded animal entering Idaho from designated infested zone now requires a certificate of inspection issued within 5 days, along with a movement permit from the state of origin. So this applies broadly, covering livestock such as cattle, horses, goats, and poultry, as well as pets and companion animals like dogs, cats, rabbits. So the screwworm is now a mandatory reportable disease in Idaho, and it gets reported to the ISDA by our veterinarians and also owners of the livestock and animals. And the state is also advising our pet owners against traveling to areas where they have established New World screwworm infestation.
It's in Texas, I know.
Yes.
Is it just a small isolated area or how?
I think they have at least 6 or 7 counties affected in Texas, mostly in the southern part of the state. And the one New Mexico case was kind of bordering Texas as well.
The area. Are they releasing more of the sterile flies?
Yes, they are. And they are also working on a new technology to improve the sterilization technique and release a new batch. And I know that the USDA is working with their counterparts in Mexico to make sure that it does not cross the border.
Trying to gear up, get enough flies and periods.
Yes, and then our Southwest District Health response, we had a very minimal role, but we did what we could. We sent out a health alert notification to our providers and hospitals in our area, because in case they see any human cases, it's important that they are able to identify the cases and also dispose this larvae and the fly correctly, because if the live larvae or the fly are released into our environment, it can establish in our region and can affect our livestock industry as well. So we did send out that information to our providers. And then, so the key takeaways is that this is the return of a pest that was eradicated from the United States decades ago. And the cases remain geographically limited to the southern part of the country. And early detection and proper disposal are what prevent establishment and spread of this fly, and effective response depends on coordination between public health, veterinary services, and also our agriculture partners. So moving on to the next topic, avian influenza or H5N1. It's also commonly called bird flu, and it's caused by an influenza A virus. It's highly contagious and can infect birds, wildlife, and humans. The H5N1 strain was first identified in China back in 1996, and it spread globally through migratory birds. It's now widespread in wild birds and is driving our outbreaks in poultry and dairy cattle. The reason we monitor it closely is that H5N1 does not spread easily among humans now, but influenza viruses have the ability to change and mutate, and once it's able to spread between humans, that becomes a concern. So both at the federal level and the state and the local level, we are trying to prevent that ability to the virus to spread and mutate. Briefly on the timeline, it emerged in 1996, appeared in US wild birds in 2014, hit the country hard in 2021 and 22, and was detected in dairy cattle for the first time in March 2024. So more than 200 mammals have been infected in the US since 2022, and human cases began in 2024, almost entirely among the farm workers, but we have not had any human cases in Idaho yet. Moving on to the next slide, in Idaho, this virus has been spreading in our dairy cattle, especially for the last 2 or 3 months. So we have currently 49 dairy premises under quarantine statewide, which is implemented by ISDA, and 14 of those are within Southwest District Health jurisdiction. And that means roughly a quarter of the affected premises in Idaho are in our region. And there have been no human cases, as we discussed, and the risk to the general public remains low. We are mostly concerned about our farm workers that works in close proximity with the dairy.
But dairy is in quarantine. That means they can't ship cattle out.
Yes. Yes, and I think ISDA also have some restrictions with regards to selling any products from the quarantined dairy.
So I can't butcher them either.
Yes, and that's temporary. I think once that quarantine is lifted, they can start selling the products. And next slide, please. At this time, we are asking clinicians to maintain awareness of H5N1 in patients presenting with respiratory symptoms or a red eye, particularly those who have worked with cattle or animals recently. The highest risk groups, again, are dairy workers, poultry workers, and nationally, there have been 71 human infections since spring 2024, including 2 deaths, all linked to poultry or cattle exposure. There are no cases of humans in Idaho, and for anyone not working around cattle, the concern is very low. The risk is very low of being infected. And our Southwest District Health response, again, we send out the health alert notification to our providers, letting them know about this is spreading in our cattle, and to keep an eye out to anybody presenting with the symptoms and had a recent exposure to cattle. And then for our farm workers, we are distributing materials directly to dairy operations, and we are also placing them where the workers gather, including markets, fairs, and community events. The emphasis is on recognizing symptoms early and reducing occupational exposure. For our general public, we have developed posters on staying healthy around farm animals and distributed it, especially where people come in contact with animals, like our fairs and petting zoos. We have also engaged our coroners and medical examiners in the unfortunate event that there is a suspected human case that they have to deal with. And the farm worker, next slide, please. This slide just shows the example of the farm worker outreach material that we developed and distributed. And we have our information, including our phone number, and we do have Spanish-speaking staff if anybody have questions about this and want to talk to us. And next slide, please. So the key takeaways, the animal outbreak is active and expanding within Idaho. We have had no human cases, but vigilance remains essential. Continued spread in cattle increases occupational exposure and the potential for spillover to humans. And the response, again, depends on coordination between multiple agencies, including ISDA, Department of Health and Welfare, and also hospitals and doctors. Next, moving on to the final topic, cyclosporiasis. It's a diarrheal illness caused by the parasite Cyclospora, which has been in the news lately. And symptoms include watery diarrhea, loss of appetite, weight loss, fatigue, and fever. It's seasonal, occurring usually between May through August. It happens almost every year. And it spreads through food and water contaminated with human feces, and outbreaks are typically traced back to imported fresh produce like lettuce, cilantro, basil, fruits, etc. And currently there is 1 active multi-state outbreak and 5 other state-level local outbreaks that FDA is investigating. A total of 4,173 cases, 308 hospitalization, and 0 deaths across 41 states have been reported this year in 2026. this year, this case numbers have been about 3 to 4 times higher than what was seen last year. So, and this is mainly due to the multi-state outbreak. Can we move on to the next slide, please? Multi-state outbreak of cyclosporiasis, which caused about 1,947 cases and 98 hospitalization. And the cases are concentrated across 9 states that's highlighted there in green and blue. And FDA's traceback investigation converged to a single supplier as a cause of this outbreak. That's the Taylor Farms in Mexico, which provided shredded iceberg lettuce to Taco Bell locations in the affected states. And Taylor Farms have recalled all the iceberg sourced from the central Mexico region, and that was distributed in the US market. And the good news for us is that the implicated products was not distributed in Idaho. So we have not had any outbreak-related cases so far. And next slide, please.
So we heard that it was caused by that lettuce, but then we heard that the FDA had to rescind that.
Yes.
So does that mean it wasn't related to the lettuce, or how definite is that?
They said it was inconclusive, so.
Yes, they tested the Taylor Farms lettuce, and first they said it came back positive for the parasite, and then they retracted that, saying it was a false positive. But the thing is that even without the test, based on the epidemiological investigations and talking to people who got sick, the most common exposure factor was this particular brand of lettuce that was sourced from the central Mexico region.
So they're pretty certain that that's where
Pretty
it's coming
certain,
from. They
yes.
just didn't have the actual
Yes,
smoking gun.
yes, and it is hard to grow these pathogens in food products usually. So mostly they'll have to rely on this epidemiological investigations. It's great if they can have a positive lab report, but it's not always a feasible thing. But
It didn't look good.
That's why we need to
yes. So for Idaho, cyclosporiasis is not a reportable disease in Idaho. So if a healthcare provider or a lab is testing for this infection and come back positive, we wouldn't get the notification. So what we are doing right now is our Department of Health and Welfare is working with our hospitals, both in Idaho and also in the surrounding states, to keep us posted if they see a case of cyclosporiasis or the lab test come back positive for a case. So based on that, our hospitals have been pretty proactive in reaching out when they see a case. And we had about 8 cases in Idaho reported since June of 2026. And 1 case reported in Canyon County, which is in Southwest District Health. And good news is all these cases are travel related. We have not had any Idaho acquired cases. So that is very reassuring. So moving on to our Southwest District Health response, we again sent out the notification to the healthcare providers about the current outbreak, what symptoms they should be looking out for, and the testing guidelines. And then we also had the social media and newsletter outreach to our community members regarding what's cyclosporiasis, how to prevent it, and if they think they have been exposed or is sick with the infection, to reach out to the healthcare provider, because there is a treatment available, and earlier the better if the treatment is started. And next slide. All right, thank you so much for your time and the opportunity. Please let me know if you have any questions.
Thank you.
Thank you.
Thank you.
We'll take a short break. Up to 10 minutes. Bill. Southwest District Health Policy Priorities. Nikki.
I'm gonna probably run these two agenda items into one another. They're a little bit connected. So in your binders, there's a document that's titled 2027 Priorities of the Board of Health, Southwest Health. And that's where I'll start. In the last several years, we've put together like policy priorities or position statements, we call them, for the board to look at. This year I took a little bit of a different approach that I'd like board input on. And it kind of came to my mind as Commissioner Brooks and I were actually visiting after the last board meeting, kind of around this, well, this idea came from that conversation. I don't know if it was actually, if it happened during the conversation now, it was a month ago. But we have priority areas that have been identified through our community health needs assessment that was done recently and published. I'll probably have staff present that to you maybe next month. But it identified 3 priority areas for 10 county region, and each county in our district had similar priorities and I think the same order too. So those were around behavioral health, housing, and access to care. And those were identified as pressing needs that, if addressed, could help improve health in our communities. Along with those inputs, the board, over the last few years has provided input on what they see as pressing needs. And what kind of came from my conversation I had with Brooks was we were talking about physical activity and nutrition. It had me thinking about the U.S. Surgeon General and how, what priorities they currently have at the federal level, and their process for kind of putting that information out. So following our conversation, I went out to see what are they saying these days? And interestingly, I felt like quite a few of their priorities also aligned with what I've heard the board members talk about, and that ties into some of the needs that I just mentioned that came up from the priority areas that came up from the needs assessment that we just did, maybe a little bit more specific. And those were around harms of screen use, social media and youth mental health, parental mental health and well-being, and social connections and other priorities. So I know those are topic areas that have been of interest to the board. I feel like tie into that behavioral health and play access to care conversation or needs that are identified through the health needs assessment. But one thing that also stood out to me as I was reading about kind of through the U.S. Surgeon General's website that I thought would be maybe of interest to the board is how they framed the priorities, and then what they kind of put out there for public consumption. And so they did, and I've kind of mirrored their process, stated why this issue matters, and then a very brief kind of what are the key takeaways. And then where I felt like maybe this process or this approach could maybe be an improvement on what we've done in the past is some very specific calls to action by different stakeholder groups. So as you'll see in here, some of these areas will have different calls to action for different groups, but we know what the topic area is. But it could be, for families, it could be for school districts, it could be for local public health or government agencies and policymakers. And I thought that was pretty interesting approach. And some of the reasons that I liked it is that it really aligns with a lot of the work that the health district does. It helps kind of give us as a day-to-day operations something to stand behind. And also, I felt like if we did some public information around this, it's a way for the board to kind of stand out as a leader in the community as well. If the board says, yes, these are the priorities, and we want all of our partners in the community focusing on these efforts in the ways that are relevant to their position in the community, whether they're a family member or business owner or a government entity. or policymaker. So that's kind of the structure that I put this in, and would love to have some input from you. There are quite a few priority areas that I put in here. Again, kind of just based on feedback, past legislative issues, and what our health needs assessment have said, what the Surgeon General's input, where it kind of aligns with what our local needs are. So I think there's 8, and that might be too many, but I thought I'd rather start with more, and we can always get some out. And if there's something that's not on here that you feel is important, then, we could talk about adding that in. Maybe just to expand a little bit too on so this doesn't replace what the strategic priorities are of health district, but where I feel like it fits into our strategic priorities are around community health needs assessments, and then as a result, working steps. So other things that we're working on, like supporting community EMS and thinking about some of that doesn't necessarily, because it's not on here, doesn't mean we don't care about it. But as I was saying with like food fees and things like that, those are still important, and we're working on those. This is more on that bigger picture of community health needs, overall wellness, health and safety of our population. So that's the approach I took, and I would be interested in hearing input on if you think this is better or it. That's fine too. And so that's this document. And then I will pause, and I think just wait to see if you guys have any initial thoughts about it. And then I also have the Kratom resolution to share with you. And today I thought you could just look at it, get some of your input. If you want to think about it, come back next month. I thought next month I could ask you to approve something. So if you like it, I can make some improvements to it. If you want me to scrap it and go back to what we did last year, that would work too.
You envision this as just as an internal guiding document?
I see it as kind of fulfilling maybe 2 roles, and I maybe didn't touch on them very well, but one is, yes, an internal guiding document. So I could see us internally. One, I think it helps us in our conversations with resource prioritization, but some of these are really asking partners to step in and help address public health problems. So when I see calls to action for, I'll just say nutrition and healthy eating here, we have some ideas for how schools and youth serving organizations can implement practices that help with improving nutrition. Same with healthcare providers and health systems. So then I see us using that, what the board is supporting as and giving us the go ahead to say, focus this on social media. When we're out meeting with our community health action teams and community partners, we can reference this. Out inspecting a food facility and we want to advocate for calories to be listed on the menu. It's kind of like throwing things out there, but those are things that I feel like could kind of give us a call to action, both internal but also external. We could even do like kind of a press release for the public to say, our Board of Health has picked these priorities based on this information, and we want our community to help us move the needle in these areas.
Because these other entities don't know that we're thinking about these things.
Yeah.
So it would have to be presented.
Yeah, it would. Yeah. So I think there's multiple strategies that we can talk about.
A committee or, a focus group or something to get them involved, otherwise. How do you do?
Yeah. So I think, that's a good question, something that I could take back, over the next month and bring back to you. But many of these are areas we're already working in.
Right.
And we already have the relationships established with most of the partners. So I think from like a systems perspective, it's pretty easy probably to implement in some of these areas where it might be more challenging. Is, and my staff might correct me here if I'm wrong, or I'll have to go back and correct myself. But like the rodent-borne disease is like that's kind of new territory for everyone. So those, not maybe all those relationships.
What disease?
The rodent, like the rodent threat for the diseases. Emerging, it's emerging.
It might be looking at and adding, like, what does implementation look like for each of these things?
Yeah, and that's kind of what we tried to do in the call to action. And these are not, this is very draft. So could definitely use some refinement probably and tailoring to our local communities a little bit more, but I didn't want to do too much work on it without getting some input from the board first before we delved into it. But I think of like the access to care, some of the work around youth, and even like our relationships now with schools and other community organizations, they exist, but we haven't said, would you be willing to do these things to help, improve nutrition or physical activity? And by doing those, we're improving health outcomes, reducing obesity, dependence on the healthcare system.
I think that's the part, the how is what we need to discuss, like, parents and caregivers to encourage, children and adolescents. Okay, well, what's the mechanism to encourage parents to do all that, or to get the information to the parents to encourage them? Send flyers to the schools, or are we going to go out with the kids? How do we do that? Otherwise, how do the parents know that we have this goal or this call to action for them if we don't have an implementation of how do we get that information to them?
Well, we have the White Health Coalition in White County that basically works with the schools to do these very things. Yeah, we've actually in Marcy, the principal or superintendent, he might be superintendent actually, is one of our main members, and Marcy has done an absolute wonderful job of getting parents involved and getting the students involved. Right. That's worked really well.
We don't have that in Jim County. So
You have a chat.
yeah, we don't have the same setup.
The same connection.
Well, what we did is we combined two, because we had the chat, and then we had another organization that was basically all private, and we put the two together because we were just doing, we just competing against each other, and it made more sense to combine. Right. And that way we had a broader spectrum of what we were looking to do.
Right. So you could pass that information through that organization.
Yeah.
Another option for communication that I think would be feasible is through the school district themselves.
Right, and that's kind of what I'm getting at, is what are the steps that we're gonna take to implement this, right?
There's some connections there, and if we, depending on the information, of course, that's getting disseminated, we can text or email that directly to all the parents of all the students within the school district.
I know there was a program, and I don't recall the official name of it, but it was like, encouraging kids to get out and play for 15 minutes a day or 10 minutes a day, or you know what I'm talking about? Yeah.
Seems to me like you can talk all day long, but unless you get to the heart of the problem, it doesn't really matter. So support to something like the rec districts. So Middleton doesn't have enough girls teams, but they've got girls that want to play baseball, softball, and they don't have enough coaches and enough referees. Seems like that's what we want. We want kids to get out and do that kind of stuff.
Right.
So talking about it, talk is cheap. That's what I think. So you can communicate all day long, and yeah, you need to do this, you can do this, but unless there's a mechanism for them to actually do it,
Right.
doesn't really matter. So that would be the physical activity and health communities should be at the top, because you can tell them to eat healthy and hopefully they will. But unless they're actually doing something, they're not going to eat well, and they're also not going to get off the deck. So if you get number two going, the kids playing sports and that sort of thing, more than just 15 minutes of jumping jacks, we would all be a lot better off. And that's the way it was when I grew up. We played baseball every day, just the kids in the neighborhood in a huge parking lot right behind our house. And we got a lot of injuries, but we had a lot of fun too.
We didn't have cell phones and.
Right, exactly. Yeah, we just went outside and played. We didn't have to worry about a whole lot of stuff that kids worry about today.
Remember that?
But even just potentially changing the structure of the school day with schools to
Right,
include
yeah.
more breaks where they go out and run around.
Exactly.
Yeah, so that's, so like on the bottom of page 6, just here, exact point, Commissioner Purdy, some of the direction that we would, recommend advocating for would be support year-round, grade appropriate physical education for all students, provide regular opportunities for movement during the school day. It goes on here to talk about intramural activities, after-school programs, et cetera.
Yeah.
And that's something that this board, this is what I'm advocating for, that this board would say to our community, this is important for these reasons. And we want our schools to come on board. We want our extracurricular and organizations to come on board. We want families to come on board, right? And to rally behind these important areas that improve the health of our children and the future generation. So that's kind of the intent of this document. Getting to that how, as Commissioner Lilly mentioned too, is something I think we can come back with next month and be a little bit more specific on the how, but it's really work, again, that a lot of my staff are already doing it, just be more specific.
Focused.
Like, yeah, and focused. Like, we're not going to try and do all the things. We're going to try and do these things.
Yeah, I think that's
And like I said, building on the relationships we already have with all of the schools, healthcare partners, and asking them to adopt policy changes or make adjustments. To your point, like, we can talk, but if nobody's listening or there's not really a call to action to do something, then it doesn't really matter. It feels good, but then the result doesn't show up. So this would be an effort to really try and push us a little bit further in the work.
It's probably a good time too, if they're starting to get cell phones out of schools. Not let you have cell phones, maybe.
Yes, Commissioner Liddy, yeah.
We're already doing.
And that is in here too.
Yeah,
So
I know that, but I'm just saying, okay, so let's keep them busy.
Yep.
And find something fun for them to do that isn't just playing games on, creepy games on phones. Holy cow.
You've had that symposium in the past and you've tried to get people to come. You don't necessarily get great attendance, but I would think that somehow presenting this information would be a great way to get, so it's community leaders,
Yeah, this is for 2027, right? So it gives us time to plan, to budget. And I was thinking, because we are going to have a turnover this year in the legislature, it'd be good to bring back the symposium. And this actually would be kind of an exciting topic, I think, to share with our elected officials that are going to be hopefully. We could do work with Monique. She's really good at this, but help us kind of build it up as something that our community should be and want to be a part of.
But I could say this was a success. Our Hawaii Health Coalition was we did a study on how many of our students felt that they were in depression, they were depressed, or around 60%. After we went in and did some discussion, did some work, and did some changes at the schools, we got that dropped down to 22%. So those are successes. These things can be done, and we just got to take the time to go out and do it. So
what do you think contributed to the most of it, the drop?
The drop
Yeah,
was mainly the children being able to actually talk to somebody to help them get through that bad time. And whether that was, part of that was bringing the parents in and discussing the issues with the parents. And that changed a lot. Just getting more of the family unit back together. That was that was a big part of why the kids felt, and of course, the social media didn't help a lot either. But if that was part of the big thing was the walls that were built between the parents and the children. And a part of that was due to their phones and all this, the social media. But part of that was just how parents are today. We don't have stay-at-home parent. We have parents go, and the kids go to a daycare center or a relative or someone that's willing to watch the kids in the evening and after school. And the kids are missing out on a tremendous amount of stuff that when we were young, we didn't have those things. I mean, our parents were there for us. And, why was it? My mom was a stay-at-home mom, and my dad, farmed, and we worked with that. And I mean, it was a lot different than it is today. These children today don't have that same way of life, and whether social media is a good thing or a bad thing, of course we think it's bad. People just say crap they shouldn't say. But I mean, because you're not in front of somebody.
It's not really a great way to communicate.
Well, and it takes the personal part out of it. It's just whereas there's no personal. And that's the problem. But yeah, like I say, Marsing and Homedale have been working on this, and we have gotten through the Hawaii Health Coalition done pretty well. The only thing bad about that is getting participants to help move that forward. It's usually just a few of us, but that's okay. We're still able to get the job done.
Well, and in addition to that, so I remember when I was a kid, we had playgrounds not very far away. If it wasn't the parking lot, there was a playground where you could play tetherball and swing and stuff like that. They were fairly close because we were just all latchkey kids. So there wasn't anybody there at home for us afterwards. And we all did just fine because of it, but we did have something to do. We went and played. We had a neighborhood, lots of kids in the neighborhood. So
It looks like Dr. Tribble has his hand up.
Oh, go ahead, Dr.
I'm
Tribble.
not sure how long it's been.
Sorry.
Yeah, hey, thank you. I think it's a good proposal, and I approve of that. I just wanted to kind of emphasize an area that I think we need to push a little harder on, and that is the cell phone use in kids. I see this just a ton, even in the ER and working with the public schools and kids coming in on phones. We just have a ton of evidence showing how detrimental this is to kids' development, brain development, dopamine pathways. And I think a lot of that activity we're talking about is being replaced by phone screen time. And so it's affecting kids' sleep, it's affecting their weight, it's affecting their grades and learning. So I think we need to focus a little bit more on that, and kind of sort of how we did with the the campaign against smoking, and kind of make it passe or a little bit shameful to have a kid that's 8 years old, on a cell phone. So kind of letting people know so that parents can recognize, like, hey, this is bad for my kids. And I think a lot of parents don't know that or haven't been informed, So that was just kind of my 2 cents and thoughts on it too.
Thank you, Dr. Knight. Any more discussion?
So I don't hear you hate it. So
My comment, I think it's really good to put things into words. We've kind of talked about all of these things. It's good to see it put into words and actual actions. It's long, so, I don't really read as much. So
Yeah.
need to be condensed, I think.
Yeah, I think what we like, this is kind of what I see as the internal kind of working document that has all the stuff that kind of justifies the why behind us doing this work. Yeah, and then I was thinking, Monique, probably on you to help talk about this next month, but especially when it comes to like public communication around it, like taking each of these priority areas and then focusing down probably to the various calls to action and target like communication towards, if we're talking about parents and caregivers, is what we want to say. And then maybe span these out like over, my guess is knowing that the community health needs assessment that we've done every 3 years over at least the last 9 years, I don't think the top 3 have changed, or at least 2 of the top 3 have stayed the same. So knowing that this is probably not a 1 year, we're gonna, you know, at the end of the year, like, we published, moving on to the next problem. So I think these can be some long-term strategies too, that we think about how we and continue to do.
Question about the community health needs assessment. I listened to that webinar the other day. So it was like St. Luke's, I think. And they presented it. It wasn't our district. It was, you know, didn't include our counties and to the north. Is that?
It included the 10 counties of Southwest District Health and Central District Health. And then there are some counties in Oregon who are included for St. Al's because their footprint goes into Oregon.
And same for
Or West.
like Murtaugh area, stuff like that. So it was like Wood River
Yeah.
area that was outside.
Sorry, it goes to District 5 too because St. Luke's goes to
Because
it.
St. Luke's goes there.
So depending on.
Well, maybe, and it was, I mean, she was talking about that.
Okay.
But, I mean, they included some information from Twin Falls.
Yes. Yeah,
But it seemed to me that it didn't include all of our counties, smaller counties.
yeah, it did. In fact, when I'm going to have Charlene, I think, come in August to talk about the CHNA, the Community Health Needs Assessment. And then one thing that they did this year is they did county-specific profiles, and we have one for each county in our health district. So I think they're just 2 pagers, but we plan to share this with you too.
And I think also it may have come across that way because St. Luke's and St. Al's, they both did their own implementation plan. So they were kind of focusing on the areas that they're serving the most, obviously, you know, Ada Canyon, because that's the biggest hospital presence.
Yeah,
But
I think that's maybe what it
yeah,
was.
and we're like, Payette doesn't technically have I mean, Payette County does, but the city of Payette doesn't. So and it's smaller, and same with Adams County only having, well,
No, that's Valley
Valley
County.
County, so yeah, there's not really St. Luke's presence specifically. So I think it may have gotten
I think
lost in the shuffle, but we all, when we were doing the CHA, like lots of different players were coming involved with all the county different information. It's just once it broke off to implementation, it was different.
That was my hope.
Yeah. We have some good stuff and Charlene can present it. I think be good to see her.
I'm not done yet.
I know.
Okay.
Is there any more questions?
Oh, okay. You are the chairman.
I'm not, I'm just here.
Want to make sure you, like, I hadn't got to the resolution yet. So I have one draft resolution to introduce. Just as a reminder, our food fee for the food safety program resolution is good for, I think, another year. So I didn't bring that. Since it's already done. But the one for Kratom had expired. So we had our staff bring it back up and update it. So you'll see, I'm not going to read this to you, but there's several whereas statements that provide the justification for what our call to action would be. And as we talked about this internal, this is an area that I would really like some board input on too. And thinking about what happened in the last legislative session with 3 different bills being introduced. I think one was maybe from Board of Pharmacy, one was from industry. The other one might have legislative bill. But they kind of covered the gamut of like full ban on Kratom to, if I remember right, some age restrictions and then maybe some synthetic versus natural. So where we've landed for your feedback is kind of 2 like this is ever really a good idea, but again, you can help us here. To kind of two calls to action. One would be like, our preference would be that we have a total ban on kratom. If that's not really feasible in this environment, and we're thinking like, maybe to get there, it's going to take, I think of like tobacco, for example. It took decades to get to where we are today with kind of public awareness and limiting access to youth and things like that. So, so there's then a second, therefore be resolved under the total ban option to increasing the age to purchase to 21, which we feel would be the next best option if we couldn't, if the state could support a full ban. So I guess my ask to you is, do you support this resolution or a resolution, and would your preference be to have the total ban in or the age restriction only, or keep both in for legislative preference? And then if the board decides to move forward with supporting one, just as a reminder, I'll then share this with my peers. They'll review it, present it to their boards, and then at the October business meeting, the Idaho Association District Boards of Health would vote to adopt this or not. And it looks like Dr. Tribble has his hand up again, and I'm not sure how long it's been up, but.
Go ahead, Dr. Tribble.
Oh,
I didn't take it down, I guess.
sorry, I didn't notice.
That's all right. I'm not
When I
not
read
sure how I do that.
it seems weird to me that we support a total ban, but okay, we'll just take 21. So, I mean, and I don't know if it really would change it or not. To me, it makes more sense to say that we support establishing at a minimum a 21-year-old age cutoff, and then say, really, we support a total ban. I think we'd be more likely to get. I mean, I don't know if it's going to make a difference or not, but
What's it used for besides?
It's a drug.
Yeah, but I mean, is it supposed to be like for PTSD, that, I mean, is that what the original, no?
Is there any medical benefit?
Yeah,
Is that what you're asking?
yeah.
Is it energy?
The fifth whereas answers. Stimulant effects.
It's a drug.
Yeah, there's no real medical benefit on this one.
And then I
And
also.
off of it, they give you Darkine.
They've
Oh,
been
geez.
trying to use it for those that have been heavily on drugs. They try to get them on kratom, and then they're supposed to wean them off, but it's the side effects of it are, they just had a fatality not too long ago. They claim it's natural. Marijuana was natural until they synthesized, they took a while and they got it, now it's synthetic. They talk about all the opioid plant is natural, but they've got it, in synthetics now. So we talk about, well, it's a natural. Well, all these other plants were natural too, but we've brought them in where they're synthetics now, and that's where the danger comes, because they're highly more. And they're just not good for you. Like I say, that gal just died from it. It doesn't make sense what we're trying to do here. I think we need to just say no. Just like we do with marijuana, we say no in this state. Hopefully we continue to do that, but we say no in this state.
I completely agree with that, but having listened to these proposals last year, I think that's going to be a stretch for the legislature to do that.
I thought if the board supported it, I thought I would reach out to the Sheriff's Association and Corners Associations and see if they would support it as well. And maybe if there's multiple voices on the same page, maybe that would have more weight with our legislature.
I certainly would support the resolution. To answer your question, so typically as a lawyer, when you plead for something, you typically go with the highest one first.
Yeah.
And then in the alternative, we want this, we want the judge to do this. So the way it's written is actually legally correct. That's how we would typically ask for relief, or in this case, for something to be done. So.
But did they already do that last year? That's what. Because I didn't know there was a,
There were like 3 different, I think, right? I remember watching 2 of them, but I heard they came back a 3rd time.
Yeah.
So I think there were like 3 different
And the
lessons.
yeah, the industry's gonna push really hard.
Oh,
They were, I think, behind the one that said, well, you know, just the synthetic kind, we're gonna restrict. And the natural one is still fine.
Just go back to natural marijuana, it's just go back to natural opioids. We can do that too, I mean, sorry, I just don't. I'm a recovering drug addict or an alcoholic, so I know the bad sides of all of it. I'm lucky to be alive.
Nikki, do we know how the other districts are gonna do something? Are they gonna do like a resolution? Because I was wondering about like Idaho Falls that banned Kratom and how that could lend weight.
I volunteered our district to write the resolution, so we get to pick. And the other boards will vote on it.
And this is for all the districts, right?
Yeah, and it would be for us first. So if like if say the full board didn't vote on to support it, then we could still, advocate for it for ourselves as a district. But yeah, the intent would be to have the association adopt it. And then I forgot to, at the beginning of the conversation, I have Lauren here and Tara on our team who's here virtually, who helped. Actually, I should say help. They wrote this resolution. So if you have any questions, they have some of the subject matter experts.
Can you talk about, let's see, footnote 2, the special topic, brief kratom, because that's what's referenced in the factor in the death of 47 Idahoans.
Yeah.
Where are you looking at?
Footnote 2.
So it's the last whereas, that it is cited, and then it's the kratom in Idaho fact sheet.
Yeah, so there's a lot of, it's considered a kratom related death. So it's important to know that the deaths that we're seeing are also linked to other opioids in the system at the time of death. And so that's where it's a little bit tricky. Was it the kratom or was it something else? And just to go back to the, what are people using it for? There is a camp that will say that it has all these medicinal properties. And so that's going to be the flip side that we're seeing at that legislature, like in the sessions. I think that from what at least I watched last session, there was a lot of anecdotal, this is what it did for me, this is what it didn't. I've also personally seen where people thought they were taking something safe and it wasn't what they thought it was. So it's tricky. It's like, was it the kratom? Was it not the kratom? We're not sure yet.
I would imagine that the people that are taking kratom are probably not only, I mean, rarely probably are they, kratom is my drug of choice.
Yes.
Probably always, also my other
I kind of
things.
look at it as an alternative
That's what they meant.
to illegal drugs.
We also saw,
It's legal, it's over the counter.
Right.
so people will see people take kratom in order to get those stimulant effects. And kratom, it doesn't show up on a drug screening currently.
And there are other approved medical ways to get off opioids like methadone.
Yeah.
So
Or
there
Suboxone.
are options for people to choose to do that. So it's not like we're taking away their only option. There's approved medical options.
And then as Dr. Tribble said too, there's no known like medical benefit of it either. So yeah, that's important.
And some additional context, there's I think it's a kratom processing plant in Meridian. So we'd be up against that as well. And so when we were discussing how to go about creating this resolution, it's like, do we want to present something that we think will go through, or do we want to present something that, like, if it has our name on it, what do we think is in the best interest of the public? And that's why we went full ban, and if not this full ban, then at least age restrictions, because that's up to the Jacksons or whoever's selling it. It's up to them if they put an age on it or not.
Part of the problem too is the cities are pushing this, and the cities are not viewed favorably in legislature these days. If you look at some of the legislation like came out about housing, how preemption was done as far as, like ADUs and backyards of cities and whatnot. So cities promoting it, it's like trying to promote a ban. The legislature is like going the other direction.
That was my point.
Yes. And I kind of feel that's the same way when the Idaho District Boards of Health does something right now too. It's
Go the other way.
they're kind of go the other way.
Even, how about if we got the sheriffs and coroners to adopt a similar resolution?
Maybe, but despite all that, I still think it's the right thing to do.
Yeah.
It's still safe because this is in our wheelhouse as far as people's health, so we should still do it regardless of how legislature is going to react. I can't control that. I can't control my vote.
They balance their budget off for
Uh,
fuel tax.
So I think I hear it looks pretty good as written. I'll bring it back next month for a vote. I just had it on here for your written guidance for this month.
Has it been to attorney look at it? Or an attorney look at it?
I don't think so, no, but I can have Mike look at it.
And I would ask him about the resolution of the resolution. Should it be one politically, but he's had a lot of experience lobbying in the state house, what his recommendation is regarding the ask. Should it be just the ban?
There's also a lot of information around,
Different than the legality of it.
there's also a lot of information around like how it should be labeled, concentrations and all of that. So there's more information on that, but we weren't sure how digestible that would be to.
Well, I think it's harder to implement the more detailed you get like that for like a store owner, for example, right, when they're purchasing product, so.
That was my impression, that differentiation between the synthetic OH form of this and that. I mean, guy that's ordering it at Jack's, be digging through the ingredients.
You know, Jackson's.
Well, I will have Mike look at that and bring back
Any
this
changes?
topic for next week. Yep.
Awesome.
Yep.
Any other questions or discussion on it? Okay. Thank you. It's director's report.
There are just our normal approved agreements, contracts, subgrants I've provided in the back of the packet. If you have any questions, let me know. And then on to the next item here, I wanted to make you aware that we had a notice violation for subsurface sewage situation that has been handed over to the Canyon County Prosecutor's Office, actually Sheriff's Office, because there's other matters involved too. They are collecting all of the information from us, what they have and what their code enforcement has for the county, and submitting that to the prosecutor's office to determine what to do.
Is this a new one or one we've already been dealing with?
It's one, yeah, that we've already been dealing with. I told you about it already, but so we'll let the rest of the board know.
Okay, tell us what it is.
Subsurface, so is it a failed?
No, I think
I.
I might have touched on this last month. It's kind of, a person moved a stormwater shed onto an elderly person's property and is living in it, and it does not have an approved sewage system disposal. And
Third time she's done this.
Started with
Some property.
Started with an electric cord and went to a garden hose, and
yeah,
there's a byproduct.
I think she's a resident of our jail right now.
well, maybe that means something.
She has work. Well, may or may not have found a warrant with her name on it.
That's cool. New information. Yeah, so she's been trying to get what we call I think it's called like a dry structure approval, right?
Yeah,
And
through the county.
application on our side, but we clearly know it's not a dry structure. She's living in it. We have photos of her washing machine and dryer and the water heater that she's
Water
installed.
filtration, she's got the whole works.
Yeah.
Oh.
Onto her storm shed. So, she has septic.
Do you count two from the?
Here lies the problem. This is her scheme. This is the third piece of property that she's tried doing this on.
Yeah.
She finds like some elderly property owner that can get bullied around and she just kind of moves her way on. And then this particular piece of property is quite large. And if this guy kicks the bucket, she's gonna try to assume ownership of it. It's very valuable. So
It's unfortunate.
paperwork needs to get lost.
Yeah, so,
Well,
yeah. And unfortunately, I mean, we've talked about our internal processes because one thing that, I mean, we became aware of this situation through a nuisance complaint that came through. But had we not had that and she came in and submitted that application, we just take them for their word that that's what they're using it for and we sign off on it. And she's not the property owner. She has no rights to the property. And that, you know,
Yeah, she would appeared as a legal applicant.
Yeah.
We would not have.
right, we would not have caught that. And it makes us think like, has this happened before? And we would not have known. And then she's basically building a case to be able to call the property her own when that person is no longer living. So I feel fortunate that we had awareness and were able to try and hopefully prevent that from happening in this situation. But it makes me wonder what process changes we could do to make sure that doesn't happen.
Sure. Do you ask when people apply for a septic permit or something? I mean, ask who the landowner is?
do you have proof of ownership?
We don't ask for proof of ownership. We ask, they have to basically attest that they are that they are the owner or the designated agent, I think is what our language says. But
you don't check it.
But we don't check it.
Put in subjects for their clients.
Yeah.
Client doesn't
Which
actually apply.
we know who the licensed installers are, but you don't have to be licensed.
Not the full permit.
And, or if you're gonna do it yourself. So, so there's some gaps. I mean, you can't, you know.
I think sometimes the assumption has been like, who's gonna wanna spend that kind of money to put a septic on a property they don't own? But if
Well, in
you're,
this case,
since a drop in the bucket, if you're gonna own a multi-million-dollar property in the end, so.
but still she submitted an application for a dry structure and we wouldn't have known because we wouldn't have gone out there to confirm that she did the dry structure.
Been like just in the old shed. You don't need a permit.
It would have been, if planning and zoning would have caught it potentially, then it might have come back to us, but.
Why does it come to you if it's a dry shed?
That's our process we have worked out with the county. They want us to sign off on those before they permit them. And there's good reason.
Even if there's no plumbing in there?
Just to confirm, I think that it's not necessary to have any kind of permits. They just are attesting that, you know, there's not a spare kitchen or a spare bathroom in their giant shop.
I think what we've learned is that like people will go through these and then they'll think, oh, I want to add something.
Oh, yeah.
Yeah.
Who would do that?
And then what ends up happening though is a ton of work for their staff and sometimes the property owner then like they have to move structures.
What if it's a if it was a dry structure and you go out there and inspect it, it's a dry structure, they're still gonna put that stuff in later. How would you get involved in that?
Well, we wouldn't.
You wouldn't even know.
Yeah. It's not only at the time planning and zoning is going out and signing off on things on there.
Is that a Canyon County thing
Or county?
for dry structures? I don't know, I think we do that.
I think it's only Canyon County that's doing that with us as far as I recollect.
You haven't received one of these in Washington, for Washington County?
To sign off on dry structures, you mean?
No,
Or,
the sewage problem. I know there was something that came across us just a little while back.
I don't recall.
I know there's one in Adams
Washington.
County that we're working.
Well, this person is putting his in 5-gallon buckets.
Oh, that's similar to the one we
That's
have in
the one in
Adams.
Adams County.
Yeah.
Dragging it down a little bit further each time.
I don't know. We should probably know about that though, because,
We're dealing with that right now.
but it's in Adams County, not in Washington.
Oh, I thought there was one in Washington County too.
Well,
There probably is. And it might not have come our way yet, depending on.
Oh, I'm sure if you get to look at any kind of ditch with cover on it, why?
be careful when you look it up.
Oh, I got ditches.
Don't go fishing.
We'd be happy to help with that though, first. As far as I know, that's not on our radar, but
Yeah,
our staff might just be working it too.
It could be that I'm not aware of it too, because it's sadly a fair amount of it. It stays very busy.
Okay, so that's that matter, and then I wanted to just give you an update on our legal counsel. The person that we were going to move forward with has backed out, so we're going back out and doing it next week. So good developments there. I didn't have on this list, but I just wanted to update you. Also, we have a meeting with Washington County Fayette. These are ambulance, and ambulance, and is it Emmett? Emmett?
It's out of district, we have, yeah.
County EMS, okay. Yes. In 2 weeks, I think, is what we're looking at to talk about the conversations we've been having around how health district or somebody could help build capacity, reduce that underutilization in 911, and pursue potentially some rural health transformation funding. So we have a planning meeting to talk through that.
Is that for the community?
Yeah, kind of building on what we've already done in Washington County. And then I think I shared with you already, but United Healthcare gave us $65,000 to expand the work in Washington County. So we met with them and your ambulance director and the medic that were staffing up there last week. We met with them last week.
We got big problems.
We talked about that.
We did discuss it in our county, and I know our county commissioners will. So Mike has our support.
I think our initial plan is to apply for rural health transformation funding once we kind of figure out what the scope is. And if that comes through, then kind of capitalize on that opportunity now and work on sustainability.
Yep.
So I'll just keep you updated on that. And Commissioner Purdy Adams County's, especially the clinic up there, has expressed interest as well. So we may loop them in too if they want to.
Can you tell us what's going on with that rural health money? I know IAC has a webinar coming up, talking to commissioners about it, but everybody's putting in for it, or what's the coordination behind that?
I don't think there's much coordination, to be honest.
The state's getting so much money, right? And that's what we're applying for, and applying for some of it. We don't really know how much we're gonna get.
Well, the legislature has that committee, right?
Yeah, there's like, I think 85 million that's just kind of dedicated to supporting EMS. That's a mix of IT, infrastructure, vehicles, and then like kind of what I'm talking about, like a pilot to try and see if there's more efficient or better way to help support EMS long term. And that funding opportunity is out there as it's coming, but we haven't got any information yet, like a request for proposals. So we don't know yet exactly what the parameters would be.
That would be what we're gonna apply for, but the individual EMS outfits, are they gonna be able to apply for infrastructure, or whatever? Are they up to speed on that?
Yes. I hope so. That's part of the conversation. Those that I've met with are aware of it. But I don't know. I mean, they have as much information as we do, and I think they're also just waiting to see what opportunity exists, what the application looks like, any strings attached.
I know our county hospital is very proactive in efforts to that.
And for them, I think some opportunities have already opened up.
They've already gathered some applications.
That seems like this, the more rural it gets, the less grant writing capabilities.
Right.
Yeah, and I know Dawn and I have talked about this too. We have Diane that can help support you guys if you are finding it. That's good to know. And I will also let you know when that opportunity is published. It just hasn't been published.
I know our EMS needs a lot. Operate on it. A dedicated staff and then volunteer staff that get very limited and pay to fill those third, fourth. We had one of our busiest months ever last month, had over 200.
Wow.
Ours was, man.
Ours keeps going up. Sorry. So we're struggling with us staffing and funding. It's a big problem.
I have one more item on here, and that is just to let the board know that Trina actually helped me schedule a board budget committee meeting, I think for next Friday. It's coming up.
Correct, August 7th.
And that is to ask for some board input on carryover funding from this last fiscal year, so that we can vote on that in August and just get some board input on it. So, that on your radar. Okay, now I'm done.
Just one more question. Your legal counsel, was that because of pay, or what was the reason?
The person who we were looking at is a one-man show, and when we interviewed him, he indicated that he would ship some work off, like for clients, and he had some cases closing up. But then he came back and just said he didn't feel like it was responsible to like kind of end some things that he was currently working on, and his paralegal basically threatened him and said, "You can't go to any more work. I'm out here." And he doesn't have an associate, so he's
Paralegals carry a lot of weight.
So he said that now is not the right time. But our other candidates were really strong. So, but since that happened, Russ, the director in District 4, retired, and we now have a new director. And so that's the reason we're doing this again. That she was not in the interviews. It's retired. Yes, the 57.
Who'd they hire?
A woman named Kristen Ryan, and I'm not sure where she's originally from. I know she worked in Alaska at the state and kind of federal level, and then moved to Idaho maybe 8 years ago, worked at DEQ, worked at Health and Welfare, I think, for a short time, DEQ for a few years, and then the city of Boise most recently.
Any other? Hey, is there any future agenda items? Hey, We do need to go into executive session pursuant to Idaho Code 74-206B. Like to ask the motion.
I would move we enter executive session for Idaho Code 74-206B.
Second.
It's been moved and seconded to go into executive session under Idaho Code 74-206B. Commissioner Purdy,
Not here.
Mr. Harper. Here. Mr. Beebe.
Aye.
Mr. Brooks.
Yes.
Mr. Welke. Aye. Dr. Tribble.
Here.
I say, we are now in executive session. Discussing
I feel just as much.
Yeah.
It's 11:48. We're now at executive session. Time, anyone want to have any discussion, or do you want to move forward with this, what the action we need to take coming out of executive session? Up to the board.
I guess I would just say that the staff for comments and reviews Nikki, I felt right in line with my own perception. I think she's a tremendous leader and a lot of vision for our district. I would support an increase up to $70 an hour.
Any discussion? Is there a second?
I second.
Well, it's been moved and seconded that we approve the increase in salary for our director to $70 an hour. Is there any further discussion? Hearing none, all those in favor?
Aye.
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 Yes. Thank you again, Nikki, and well deserved. Thanks for all your hard work and what you do. Is there anything else that the board would like to discuss?
Mr. Chairman, did that include the contract?
That we will, I want to get the contract done next month.
Oh, okay.
So we have time to look at it and absorb it, and then next month it will be on the agenda.
Have the attorney look at it.
Yeah.
Okay, sounds good.
Thank you. Thank you. Thank you all.
She could give you more.
Well, so that way